Now I call upon Dr. TVS Gopal. He's going to enlighten us on ultrasound guided blocks, basics of ultrasound.
Respected chairpersons, ladies and gentlemen, a very good morning to all of you. After the stimulus from Sailesh, it's time to move on to basics of ultrasound. The Vitruvian Man by Leonardo da Vinci is a perfect example of human anatomy. After failures and complications with blind techniques came the era of peripheral nerve stimulation and later on today, that of ultrasound. Less than 2 decades ago, ultrasound was all Greek and Latin to us practicing anesthetists. And it has been a journey for us that we were self-taught and we learned how to use ultrasound. This review by Peter Mahofer and colleagues was published in the BJA in 2005. And in this article, the authors predicted that in 10 years' time, ultrasound would become an integral part of the anesthetist's armamentarium, and ultrasound technology would be integrated into the teaching curriculum for anesthesia residents. It takes an extraordinary person to set off a revolution in process. Lazzaro Spallanzani, an Italian scientist, first discovered that blind bats navigated in the dark without striking objects in the path, and this they did because they emitted certain sound waves which only they could hear. The transformation of ultrasound machines from bulky card-based ones to portable, sleek handheld machines heralded the onset of point-of-care ultrasound. But again, die-hard critics will tell you that you don't need expensive gadgets to swat a fly. So what is ultrasound? The human ear can hear sounds between 20 and 20,000 hertz, and any sound that exceeds 20,000 hertz qualifies as ultrasound. As you can see from the picture at the top, ultrasound is a form of mechanical sound energy that is propagated as a longitudinal wave in the biological tissue that is being imaged. As you can see in the picture at the bottom, the emission of ultrasound is not a continuous process. It rather occurs in intermittent trains, and each such intermittent train is called a pulse. This is the inside of a transducer or a probe, and the patient end of the transducer is lined by an array of piezoelectric crystals. When these crystals are stimulated by an electrical charge, they set off a wave, the ultrasound wave, which is propagated in the direction of the biological tissue that is to be imaged. A transducer, as we all know, is a device that converts energy from one form to the other. To begin with, electrical energy is converted into sound energy, and in the reverse direction, sound energy is converted again into electrical energy. So this is called the piezoelectric effect and the reverse piezoelectric effect. So when sound waves are emitted, several of these can happen. These waves can be scattered within the tissue. They can be transmitted through and through the tissue. They can be refracted or reflected back to the transducer. It is these waves that are reflected back to the transducer that give you an image of the tissue on the screen. So depending on the interaction of the sound waves at interface with biological tissues, the tissue that you would wish to image could be anechoic, isoechoic, hypoechoic, or hyperechoic. These are transducers or probes, and of interest to us is the transducer that is at the bottom, and for obvious reasons, this is called the hockey stick probe, And this lends itself to pediatric applications owing to its very small footprint. Basically speaking, there are two types of transducers. A high-frequency transducer, which gives you a very good image, but the depth of penetration of high-frequency waves is limited. On the other hand, a low-frequency transducer penetrates much deeper into the tissue, but the quality of image that you get with a low-frequency transducer is not very good. Just the same way that you have in your laptop, the interface of an ultrasound machine has several controls. And though this does look baffling, all it takes is a few hours of familiarization to comprehend all these knobs. Modern day ultrasound machines are engineered to have certain presets. By that I mean that if you select a particular tissue, for example a nerve, the ultrasound machine auto-adjusts its imaging capabilities to highlight the selected structure, which is the nerve. Gain is akin to the contrast function on your television sets. Gain is a mechanism which allows for amplification selectively of returning echoes so as to present a homogeneous image on the screen. So the gain has to be just right, neither too dark nor too bright. Depth is adjusted so as to have the structure of your interest at the center of the screen. Transducer orientation is very important. Whether you keep the transducer to the left or to the right, it is very essential that you maintain constancy with regard to placement of the transducer with reference to the index marker on the screen. Because if you don't do this, you will lose sightedness of structures. So let us look at the basics of sonoanatomy. An artery, for obvious reasons, is black or anechoic, but you will be able to recognize an artery because it pulsates. A vein is also anechoic, but you will be able to point out a vein because you can compress the vein with the pressure of your probe. A muscle is surrounded by hyperechoic or bright fascia, whereas the muscle as such is hypoechoic. Now, modern day machines are two-dimensional machines. That's why we call them 2D echos. And they will give you an image either in transverse plane or short axis, or sagittal plane or long axis. So that's why we say two-dimensional ultrasound. If, for example, there is a machine which has the capability of giving you an image in an additional plane, which is the coronal plane, as you see in this particular picture, you would call that a 3D ultrasound. But when you say 3D ultrasound, you're actually talking of reconstructed images. You're not talking of images in real-time motion. If you have a machine that will give you an image in all the three planes, the transverse plane, the sagittal plane, and the coronal plane in real-time motion, that becomes 4D ultrasound. So here, the fourth dimension is time. Christian Doppler discovered the Doppler effect. And it is important to have this Doppler because a Doppler allows you to quantify blood flow within a vessel. And it is also essential that we know how to identify an artery or a vein because oftentimes nerves and plexus lie in the vicinity of vascular structures. And when you're performing a block, it is quite likely that you could have an inadvertent puncture of an artery or a vein. And worse still, if you're beginning to inject your drug and you don't see the spread on the screen, that obviously means that you're intravascular. So as you see here, the probe is a stationary listener and it emits waves towards a vessel. If the particular column of blood within that vessel is moving away from the probe, the returning waves are at a lesser frequency, so this particular vessel will appear as blue. On the other hand, if the column of blood is moving towards the probe, The returning waves have a higher frequency than the emitted waves, and this vessel will appear as red. So in Doppler terms, all arteries are not always red, all veins are not always blue. It is the direction of blood towards or away from the probe that governs the color. So when you use an ultrasound probe, there are certain maneuvers that you will need to undertake, and PART, P-A-R-T, is an acronym which is easy to remember. P stands for pressure. You need to apply the right amount of pressure on the patient's skin. Alignment is A, and you need to align the ultrasound probe with the structure that you wish to image. And you have to rotate the probe so as to align the needle with your particular probe. And you can also tilt the probe to the left or to the right in an effort to avoid anisotropy. There are basically two approaches. You will be seeing this in the Live Blocks workshop very shortly. And approach one is the in-plane approach, wherein the needle is placed along the path of the ultrasound beam. And approach two is the out-of-plane approach, wherein the needle actually is placed across the path of the ultrasound beam. And only that part of the needle which transects the ultrasound beam is seen as a bright spot on the screen. And this is not to be confused as being the tip of the needle. So when you do blocks repeatedly, there is something called ergonomics, which helps you prevent injury to yourself. So in this particular picture, the ergonomics that I've adopted are wrong. And in this particular picture, the machine is positioned in the correct place, and I'm adopting the perfect posture. So if you wish to buy an ultrasound machine, today you have a cafeteria choice. There are so many manufacturers in the market, which is good for us because it eventually helps in bringing down the cost of these machines. But you would want this machine to be portable, lightweight. You would want the machine to give you a very good quality of the image. And you would want at least one transducer, which is a linear high-frequency transducer. The machine should have color Doppler, and you should be able to archive your images so that you can retrieve them and use them at educational events such as this. Modern day machines place a lot of emphasis on high quality resolution, and multi-beam technology helps in achieving that. Needle visualization with ultrasound guided blocks, as you will see in the workshop to follow, is quite a challenge. And manufacturers of modern day machines have incorporated certain technologies by which you can actually pick up your needle while performing your block in a much better manner. This particular machine has a transducer which goes up to 24 megahertz. Higher the resolution, better the quality of the image, and better the ability to be able to delineate anatomical structures. This particular machine has wireless transducers with handheld depth controls. And there are certain machines today in the market which incorporate a tutorial so that it can be of great help to the novice anesthetist when he or she is starting out to perform blocks. They can watch the video, they can read the notes, and then they can proceed to perform the block against the background of the images that are present on the screen. So, to conclude, ultrasound revolution in modern day medicine has well and truly begun, and the concluding part to this evolving saga is not likely in the foreseeable future. Thank you for your attention.